Thank you, Sarah. I had to get approval from Sarah to record. Okay. Welcome, everyone. Happy Friday. Thanks for joining us. This is the Public Health Advisory Board's Accountability Metrics Subcommittee. So I'm very happy to meet with you all today to keep going on this conversation. You all received the meeting packet, so I'm going to share my screen and walk through our agenda first before we get into the discussion. But you should also, yeah, have the meeting packet if you want to follow along there. So I'm going to share my screen. I'm kind of just jumping in, but I hope everyone's doing well. Sunny Friday. Um, so for our agenda today, welcome again. Um, Based on our conversation last time, we thought we would start the conversation with a brief review of the PHAB accountability metrics framework that y'all put together when you were developing those initial outcome metrics and process measures for the communicable disease and environmental health foundational program areas because we felt like it supported a lot of the conversation you had last time around having both kind of standardized metrics across all local public health authorities and also the opportunity for more flexible context specific metrics. That was kind of a core piece of the conversation last time, and we felt like the framework that you all developed previously certainly supported that. So just wanted to kind of ground us in that framework again. And then plan on spending the majority of the time reviewing and potentially refining, or at least having a discussion about the selection criteria that you all want to use as you get further into reviewing and prioritizing metrics for the Prevention and Health Promotion Foundational Program. So again, primarily in this review metric selection criteria item. And then to kind of wrap up the meeting, wanted to discuss the process for gathering those potential prevention and health promotion metrics for your review, application of the selection criteria, and ultimately prioritizing those metrics. So we'll discuss the proposal for kind of casting the net and gathering those potential metrics. We'll have our public comment period, and then we'll adjourn and kind of discuss the content for the next accountability metrics subcommittee meeting. So I'll pause here and just double check that that sounds like what y'all are here for. Any questions or any other items that you were hoping to get to today that you're not seeing reflected in the agenda? Oh, meetings from the July meeting. Is Valerie on?
Valerie's out today.
Oh, sorry.
Part of why Steve and I are scrambling.
Yeah, apologies. Um, I need to check on the July minutes. Apologies that those were not included in this packet. And that will be something we need to follow up on. Apologies about that. And thank you for that prompt, Florence. I'll try to stay more on top of capturing and sending out the meeting minutes for folks who aren't able to attend. So next time we meet, you'll have both the July minutes and the meeting minutes for this meeting, and we can review and approve those. Okay, I'm gonna keep going. Okay. Just a friendly reminder about the focus that y'all selected for this subcommittee, was to work on developing metrics for the other foundational programs that aren't yet reflected. That's a good question too. Are Florence and I the only subcommittee members on? Veronica, Florence, Harriet? Yes, I believe so. Sarah and Florence are our reps today. Very essential, crucial reps. Thank you for being here. Um, yeah, so just a reminder that this group decided you wanted to really focus your time on developing metrics for the other foundational programs in the modernization framework that aren't yet reflected, which would be prevention and health promotion and access to clinical preventive services. Wanted to start the conversation with that prevention and health promotion area. In addition to thinking through kind of population level health outcome indicators and LPHA and Oregon Health Authority process measures, you also wanted to ensure that through this process, could potentially develop related equity benchmarks, also potentially think through what indicators could be included in the metric set that reflect policy and systems change measures that affect our ability to meet or achieve those health outcomes you'll select. So again, kind of equity benchmarks and policy indicators within that conversation. And then also a reminder that the group was also wanting to, when it makes sense in this process, to connect with the Oregon Health Policy Board Metrics and Scoring Committee so that we can ensure that your work on prevention and health promotion metrics aligns potentially with the metrics for CCOs. So identifying where there's, yeah, alignment there and we are working toward a shared purpose. So just friendly reminder about what you selected. Um, and then again, the purpose today, just take a refreshed look at the accountability metrics framework, review and refine the metric selection criteria, and discuss a process for kind of gathering the prevention health promotion metrics that you all want to consider in future meeting. This was our timeline we had talked through with the major steps. We're still at that first step of really identifying the approach and the selection criteria before we head into review existing metrics. And again, don't probably need to spend a lot of time on this framework because you all created it. But it felt important to just ground ourselves in it based on the conversation last time of wanting to balance both standardized metrics that could be tracked across all local public health authorities with some flexible context-specific measures. And so we thought that was already pretty nicely reflected in the framework you developed, where you have this question of what priority health issues are there throughout Oregon we want to track, which we can do through standardized health outcome metrics like we have for the communicable disease and environmental health areas. But then we also have these questions around which groups experience disproportionate harm, which might lend itself well to the equity benchmarks we've started to think about, and you want to bake into this process, as well as how are policies contributing to or eliminating root causes of health inequities, really feeding into the recommendation you all had to consider policy indicators as well within the metrics set. And then lastly, wanting to note the other side of your framework, which is really focused on how public health authorities are increasing capacity and expertise related to the workforce. And that really speaking to the context-specific kind of process measures that you developed in those other foundational programs for OHA and local public health authorities. So yet another area where there can be some like flexibility baked into whatever metrics are selected for the prevention health promotion area. And then a nice little look potentially at what this looks like. Wanted to pull this visual from the recent accountability metrics report, where on the left-hand side, we do have these LPHA process measures that I'll zoom in a bit. And the content's not necessarily important as much as just the acknowledgement that we have these process measures for LPHAs that they, can select which ones make sense for their local communities. They're not expected to work on all of them. So there is that kind of flexibility baked in that we had talked about last time that responds to the context and the priorities of communities. But then we also have down here these health outcome indicators that everyone's working on, kind of regardless of where they're situated. So I don't know if the group needed this kind of refreshed grounding in the framework and how it's been kind of operationalized. But we thought it might be helpful to start with that because there was so much discussion of balancing that standardization and flexibility, and it seems like the framework lends itself well to that. already. Oh, you're right. I was originally going to use syphilis and then change my mind and then never change the title. Thank you. I will fix that before these slides are sent out. That's
See, Stephen, how
embarrassing.
well, see how well we're following along?
I know, it's impressive. You could almost think that I included that as like an attention check. So you were all successful. Thank you for pointing that out. I'll get that fixed before these go out.
Hey Steve, could I mention that we actually have the accountability metrics final and ready to share out? We've got finally got it approved earlier this week. And now we're just waiting for it to be posted online so we can share a web link. But soon, instead of seeing screenshots, you will be able to see the full report. It's a report of 2023. And we're working on the report for the full biennium right now too.
Yeah, thank you, Sarah. This little screenshot is just a teaser. So we can, in the follow-up materials, maybe include a link to that report online. Thanks, Sarah. Um, And then lastly, again, with kind of the frameworks piece, and then we'll get into the main part of our agenda. Again, just wanted to kind of ground the conversation and refresh everyone with some of the kind of framework considerations that you all have expressed in the past around the direction you want to head with the metrics framework and metrics in general for modernization. And I won't necessarily read through all of this. But again, I feel like this really does reflect well the conversation that you all had last time around, to the extent possible, identifying equity indicators, policy indicators, in addition to those population health outcomes and more workforce process measures. Um, and to the extent we can, reflecting the context around social determinants and um, existing systems of oppression. So yeah, just wanted to put this up here, kind of past conceptions of accountability metrics and the new metrics framework that you all are hoping to really move forward with, and feel like it reflected the conversation last time nicely. So I'll pause here. Again, I don't know if this was helpful, but Sarah and I, in reflecting on the conversation last time, thought that balance of standardization and more context-specific measurement is already pretty nicely reflected in your framework and the intent for metrics that you've stated in the past. So just wanted to ground the conversation in this again. Um, but yeah, I don't know. Any thoughts, questions, observations before we head into the conversation around the selection criteria? Okay. We can always come back to like framework and overarching purpose if we want to. Um, so for the discussion of selection criteria that you all will eventually be applying to the list of prevention health promotion metrics, you all said trying to make this bigger. You all said a good first step would just be to revisit the selection criteria that was used in the process last time for those communicable disease and environmental health metrics selection. I'm not doing a good job trying to increase the size. Um, Zoom. Okay, that's not working. Is this big enough? Should I keep trying to increase the size? Why?
I have it bigger in the packet as well. So
Oh, great. Okay.
thanks.
Thank you, Sarah. So, Sarah and Florence, is it an okay process just to kind of walk piece by piece of the selection criteria framework and just start to get kind of thoughts or questions we have about them, whether they feel relevant still, whether you want to make any updates or changes. And then, at the end, after we've seen all of them, we could also talk about any gaps or new selection criteria you would want to employ?
Sounds good.
Okay, awesome. So the first area of the selection criteria framework was advances health equity and an anti-racist society. And you had indicated that this framework component would apply to both the selection of those health outcome indicators as well as OHA and local public health authority process measures. The actual criteria to kind of operationalize that were that the measure addresses an area where health inequities exist. The measure demonstrates zero acceptance of racism, xenophobia, violence, hate crimes, or discrimination. And the measure is actionable by state and local public health through policy change and community level intervention.
Mhm.
Any questions, thoughts, still feels relevant?
Feels relevant to me.
Okay. And do you feel like you'd be able to apply these selection criteria in the same way for prevention health promotion?
Yeah, I honestly, for prevention and health promotion, I think a lot of these criteria are going to be easier than for communicable disease response. So yeah, it feels good.
Okay, that's a good point. Okay, I'll keep
Steve,
going.
this is
Yeah,
Sima.
yeah.
Um, One thing I'd want the subcommittee members to think about too is when we think about what you mentioned earlier, and I wasn't at the July meeting, just listened to some of the recording, is with any type of equity-related benchmarking or thinking through in the bigger model, the framework, where there's the collective responsibility versus having equity-related issues. We focused only on the state and local public health responsibility. But I don't think that you can do equity related work without collective responsibility. And so this selection criteria is really looking at state and local public health. And I just wanted to bring that up, that that would be what we were looking at again here.
Mhm.
And so the overlap between really thinking about equity as advancing it, but with only looking at our actionable selection criteria being state and local governmental public health actions is that's where we were before. And I just want to confirm that that's where our subcommittee members are currently thinking about as well as we think about these two things. But I do think there is a significant, there's overlap there. And I wanted to bring that up.
Thanks, Kasuma. Yeah, Florence.
Kusuma, thank you for the question. That makes me think. So just a few things. I was brand new to this work, never was involved in the framework and the accountability metrics before. And second, I was not at the July meeting. So pardon me if the conversation has already happened. But that made me think about your question, and kind of like this makes me think about some conversation that we've had at PHAB, and Sarah present. You might maybe remember them from our colleague, which for some reason I am not remembering their names, works in university, and really brings about this, or I think how I understand what it brings about is really these questions of accountability and how do we bring that accountability, um, thank you, Ryan, um, outside of just the state public health division and the local public health authorities, right? Because if this accountability is not carried through our legislature and how we set policy in the first place, um, then maybe Kusuma, this is where you're trying to get to, is that we need to be very, very clear of the limited um, almost reach that we have. So we can do as much as we can within a certain confine. And if that confine is not um, asked to be more accountable, then I feel like this is almost like, when you do research and you're stating your, I'm so sorry, I've spent I was about to say a month speaking French only, so my English words are not coming back. but you have to express kind of like the limitation of a study or a research project. And I feel like this would be our limitation, and we would need to, right, either say we're going for it and we're going to ask for this broader system accountability, or if we're not quite ready for various reasons, just say this is the confine within which we're intervening.
Absolutely. I think that's a great point, Florence. And um, Ryan, Dr. Petaway was in the last work group meeting and I think spoke to this quite a bit um, and why I think the group is wanting to, in this round of metrics development, prioritize and think through some of those policy indicators um, that maybe we have like less control over, but can at least like point to in our metrics framework as like a necessary step in achieving some of these outcomes to maybe create a broader sense of accountability. Um, so I think it's a great point having, those like process measures that we have more direct control over as state and local governmental public health. We have these health outcome measures that hopefully there's this collective responsibility around, and then some of these equity benchmarks and policy indicators that um, might imply some accountability in the larger system for us to communicate about. Kasuma, you posed the question and Florence gave, I think, a lovely like thought and response, and I just want to check to see if you have any other thoughts.
Yeah, I think it's mostly going back to the framework, and the framework for the CD and EH measures was solely focused on governmental public health. But when we think about equity-related measures, I don't see that. I mean, I think knowing where we're asking for some collective responsibility and partners outside of governmental public health would be important, I think, to address. And are we just saying that we're just going to focus again on local and state governmental public health this round? Because I think that plays into um, the selection criteria and really addressing the fact that we're not fully addressing equity. We're not including our partners' accountability in these spaces. So that's just something I wanted to, yeah, and maybe it's looking at that. And I think, Steve, you have in the agenda to look back at the framework, but I think the framework and the selection criteria go hand in hand together.
Absolutely. Thanks, Kasuma. Florence?
And then I had another thought or question that came up, which is, and I think to Kusuma's point, I don't remember when the original framework was created or thought through, and maybe it was done at a time where our system maybe did not like officially or overtly include our CBO partners and the various other parts of the system. And so is there also an opportunity for us to broaden the framework in 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 such a way that we would be able to then bring in the expertise and various contributions of our CBO partners and other partners towards kind of like contributing to those accountability metrics overall. I don't know, just something that came to mind as well.
Yeah, I think I mean, it is so challenging because our work is done, definitely in partnerships and CBO work is funded as well, but just we are struck with the legal framework of the accountability metrics and leading to potential incentive payments. So I want to be aspirational with it, but I also want to make it really doable for our staff to actually meet the criteria that gets the funding appropriately. It's I think there's a lot that we can work with around, showing the governmental public health, the LPHAs have partnerships and are looking at the oh gosh, what's the name of that? We're all having word finding problems today. The document that we just had around the equity framework of how we work with CBOs, there maybe even be criteria, like potential indicators of using that. But you know, we are working within the confines of our statutory requirements as LPHAs. And how to do that without increasing the stress of staff, of like making it undoable. It has to be very actionable things that can be measured in, you know, traditional public health science data brains, that's going to help our staff feel supported in the work that they're already doing, right? If we can find things to um, really show the benefits of work that's already happening. Yeah, that really happened a lot with the syphilis metrics. Is I found staff to be like, oh, we have this new work to do, and it's like, no, 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 this is work you're doing already. Like we have to really frame it in a positive way of what is happening that we can actually measure and show the good work of LPHAs in the framework that we're in, right? And at the same time, the overarching thing is that we may need to like change the whole, you know, statutory framework that we have, but that's a big step. I don't know if we need to or not.
Thank you, Sarah.
Yeah.
I think that's a great point. Like throughout the process, considering both that like aspirational piece and reflecting accountability across the different partners of the system while also ensuring that, especially to your point, those measures that are tied to incentive payments are like very tangible, reflect work that's happening that we know contributes to the health outcomes. So we aren't making that overly difficult. Appreciate it. Okay. Great. We have lots of notes on this one that we can bring through the process. Let's move on to the next one. Sorry, let me find my cursor. There we go. So the next area of the framework was community leadership and community-led metrics. Again, for both health outcome indicators and process measures. And the statement to operationalize it as a selection criteria is communities have provided input and have demonstrated support for that particular metric. Any questions, thoughts, concerns about this one? I'm curious last time from folks who participated in the process how this was um, like known or captured or like when a metric was being proposed, how did people indicate whether it was you know, based on input from community?
This is Sarah. So it was a lot of sort of, we asked public health division sections or local public health authorities to share ways in which they had heard from communities about these topics. So, you know, we collected a lot of information about what different ways communities wanted to be working with governmental agencies around vaccines and making them available during the COVID pandemic. So we kind of took that information and applied it here. We didn't do any like direct outreach around these metrics before they were finalized in communities. Um, and the reason I mention that is because when PHAB voted to adopt this first round of metrics, they did identify that as a gap or a concern.
I also will add that I think some of the LPHAs were asked, a couple reported that there was in their SHIP, you know, or their CHIP, sorry, plan, and that they got community input through that process as well.
Thank you both. Okay, that's helpful. to know how we kind of demonstrated that last time, and then also potentially maybe baking a step into this process as we get further along with the metric selection to figure out how we want to bring community into the process potentially. If FAB identified that as a concern last time. Okay. Okay, the next area is provides context for social determinants of health, systemic inequities resulting from systemic racism and oppression. This was indicated for the health outcome indicators. And then the criteria are information is available to provide the community, societal, systemic, and political context that creates and upholds inequities. And opportunity exists to triangulate and integrate data across data sources.
I have to say this one's a little bit um, less tangible for me to understand. Sarah Kasuma, do you have any like information is available to provide context that creates and upholds inequities? How is that set to a particular metric? How has that conversation happened before?
I think the thing I can share is, in the way that we're reporting metrics. So before we had this in place, we would just show the data and nothing else. And, now with the metrics, we're sort of just in narrative form providing the broader context around the issues that contribute to that health outcome. It's sort of an intentional shifting the focus to like structural causes rather than it looking like individual choices or individual behaviors.
So I see it as if we're looking at a particular metric that we're trying to select, then that metric has to both show be something that addresses health inequity as well as an understanding of how that inequity um, developed. That is something that can be changed potentially. Is that so? The information is sort of we have the basis on why this particular metric is showing was developed through. And okay. The wording is just funny, and I can't speak really well today. My wording's really funny too. So thank you for that. I think that's good.
Yeah, thanks for the question, Sarah, because I was struggling too. And then other Sarah, thank you for describing how we've kind of operationalized this. And maybe between now and the next meeting, we could think of maybe how to word this a little differently to reflect how it's been used and applied, so it's a bit clearer. Awesome. Okay, I'll keep going unless there's anything more on this one. The next one is disease outcomes used as indicators of progress. These are secondary to process measures of public health system accountability. This applies to the health outcome indicators. And then we have several descriptions of how this is operationalized. The issue has been identified as a population health priority by community members and/or public health professionals. Data are reportable at the county level or for similar geographic breakdowns, which may include census tract or Medicare referral district. Updated data are routinely available to ensure that the public health system does not rely on data that are old, outdated, or no longer relevant. This may include data from other sectors. And then lastly, when applicable, data are reportable by race and ethnicity, gender, sexual orientation, age, disability, income level, insurance status, or other relevant risk factor data. So it seems like we have the identified as a health priority by practitioners and/or community members, and then a lot of aspects about the available data so that we can track it over time, including the granularity at the county level by kind of subpopulations, and that it's collected in a routine, timely manner. Any questions or thoughts about this one?
Steve,
I gotta say, I
oh,
really like it. It really depends on which county, right, we're talking about. I mean, for us, like as a rural small county, like we're really liking the opportunity to get that granularity at subgroup and population levels just because of the low numbers. Um, I mean, it would be wonderful to be able to work on finding ways for kind of like um, smaller areas to be able to get access to some specificity around their data.
Thank you, Florence.
Hmm.
I'm
Oh,
reflecting on this as well in the, current federal uh, data world. I think it's good to have it clear that this is an expectation of Oregon's public health system that data are collected this way, which can, give us some oomph to push upward, I guess. Um, but I think it is important to say when applicable or, as much as possible, because I know that many of our federal partners may not be able to collect that data for very different reasons than Florence's, the rural counties cannot collect it. So yeah, considering to look at ways that we can identify um, relevant risk factor data that works. Yeah. But yeah, I think I like it too.
Awesome. Awesome. Great. So I'm hearing it's a good one and we like it. And maybe we can update, oops, sorry. Update with some language around like as applicable or when possible. Um, and maybe alluding to like you were saying, Florence, if there is a gap for a particular indicator and being able to have granular level, county level information, that's kind of like a call to action to figure out what we could do. So framing around this being an expectation that we're striving toward.
Steve, this
I
is just,
wonder,
oh, sorry, go ahead, Sarah.
no, I wonder if something around uh um population density is, I mean, that's sort of zip code potential data that could, it may not help within a rural community, but within the state of Oregon, really identifying kind of disparities based on rurality and urbanness, I think is something that would help all of us. Um, just as something interesting to think about that's not listed in those potential risk factors on the next screen. Sorry, because I meant to interrupt you.
Thanks, Sarah.
Yeah, the only thing I was kind of thinking about is um with this, like we say, maybe it's just wording, Steve, but it's just disease outcomes used as indicators of progress. And but also that those are secondary to process measures for indicators of progress. But thinking through, and this is like a seed for later, is just more proximal process measures that are before we get to those health outcome indicators of progress. So demonstrating progress um, on some of those process measures, or we have some outcome indicators that are more immediate than the health outcome measures.
Mhm.
Um, so just wanted to plant that seed for the subcommittee members for later. And I dropped in Healthy Places Index from California. I really think that they apply a race and place framing to neighborhood level data. And I know we've talked about this before in the past, but that could be another thing just to take a look at and reference Sarah, given Sarah Present, given your comment that you just made just now.
Thank you, Kusuma. I love that idea of, especially for prevention health promotion, exploring along that continuum of like workforce process to health outcomes, what happens in the middle that we could also potentially be capturing. It's a great idea. And thanks for the Healthy Places Index. I always love having a place to start looking. Awesome. Okay. Um, Sarah Bedreau, could you give me a time check? What time did we say we would? We have like 10 minutes left.
I think we should be fine if we shift to public comment by 11:55. Or are there some like businessy things you need time for, Steve?
No, I don't think so.
Okay.
Yeah, I think our next steps are pretty apparent, so probably don't
Okay.
need to talk through those. Okay, so we'll transition to public comment at 11:55. Okay, thanks. So we'll move on to the next item, which is focus on governmental public health system accountability, applying to both the process measures and the health outcome indicators, and also focus on data and data systems, community partnerships, and policy, which was specific to the process measures. So there are several criteria for these areas. State and local public health authorities have control over the measure, which includes influence. The measure successfully communicates what is expected of the governmental public health system, specifically state and local public health authorities. The measure aligns with core system functions in the Public Health Modernization Manual. It allows for each public health authority to tailor how work toward achieving the metric is implemented in order to be responsive to local context and priorities. And context provided shows how locally tailored metrics are working toward common goals. So I feel like that one reflects a lot of that flexibility conversation we've been having. Data are already collected or a mechanism for data collection has been identified, which could include establishing data sharing agreements with other sectors, updated data available on an annual basis, funding is available or likely to be available. That feels particularly relevant in our current context. Local and state public health expertise exists. Changes in public health system performance will be visible in the measure, and the measure is sensitive enough to capture improved performance or sensitive enough to show difference between years.
I think the people who put these together were doing a pretty darn good job. I like it.
Great.
Um, I don't know if we want to say on updated data available on at least an annual basis. There might be things that we, I don't know. That's just wordsmithing.
Any other thoughts about this one? Is there any concern about the funding is available or likely to be available, just given some of the funding chaos right now?
I mean, it's always a concern, but
Yeah.
we want to focus on things that are most likely to be sustainable. So I think it's reasonable to keep it there.
Okay.
Um, I think that having it in the modernization manual is important. I don't know if we want to add something about statutory requirement on that bullet point. But I also think I don't know that I feel strongly about that because I think modernization is still an attempt to get away from just doing statutory requirements and actually having a modern system. So I don't know that I want that in there or not. I think this is fine. I think also, having a metric selected sometimes can be leveraged for funding,
Hmm.
um, which I read into that line. I don't know if we
I
wanted to
think that
add.
was, oh, sorry. I was going to say that was, I think, the crux of my question that, like, just because funding isn't currently available, would it kick out a metric that, like, feels important that you would want to include to then, to your point, maybe drive the conversation around funding or drive a funding request?
Right.
Okay.
We would just have to be mindful of the capacity to actually collect the data, analyze it, and so if there is no funding available, we might have to really like be clear and specific as to how we are hoping to use that metric, right? I don't know.
Yeah, and I think with our current metrics on EH, environmental health and communicable disease, um, I feel like, capturing their challenges to funding and the contextual information around the lack of, like the declines in funding and staffing are important to capture, even though we still have that as a metric going forward, the existing metrics.
Okay. Any other thoughts on this one? I think I'm going to stop us there on the selection criteria. In our next meeting, we can finish up this last one. We have a couple minutes before public comment, and so I wanted to just get your initial thoughts on the process that we want to use for kind of gathering the world of potential metrics for prevention and health promotion. Um, we are thinking that a good starting place could be bringing to you all the relevant prevention health promotion metrics from the state population health indicators um, that have been already been kind of prioritized by the public health division for tracking over time. Sarah Boudreau can speak more to that if you have questions. Oh yeah, Sarah.
Are those reflected in the state in the ship, or is that a separate?
It it will be reflected in the new ship. So we'll have a new ship in, this fall, and we're getting ready to publish the state health assessment with the list of like 34 indicators.
Okay.
Also working to get them online, but there's nothing super easily public with that list right now. Happy to
Okay.
share it though.
Awesome. Great question. It's great that there will be that alignment with the new ship. Okay. And then just other proposals again for your consideration is that in addition to using the relevant state population health indicators, requesting other metrics that aren't reflected in those indicators, but OHA Public Health Division programs are prioritizing and tracking and may be included in their strategic plans at their program or section level, just to kind of expand that list. We were planning to attend the Conference of Local Health Officials Health Promotion and Prevention Subcommittee to determine how local public health authorities want to and can contribute to this metrics discussion and kind of populating the metrics for your consideration. We're also thinking about reviewing the current CCO metrics to identify areas of topic alignment, potentially pull those measures in for your consideration. And so, yeah, question is, does this approach sound okay as a next step for starting to gather that collection of metrics that you would then be applying the selection criteria to, and any other thoughts that you all have for kind of metrics gathering.
I'm okay with the approach that you just presented. I think it's pretty thorough, and I like the encompassing of the CCO metrics. And I think it really like takes into consideration like previous conversations that we've had. So thank you.
Okay, great. Thanks, Florence. Sarah, any final thoughts or questions? Sarah present? No. Okay, great. Well, we will move forward with this approach. And sorry for being over a minute, but we will now, I'll stop sharing my screen and open up for public comment. Thanks everyone for joining. Okay. I feel like I gave a sufficient amount of silence. So no public comment, but again, thank you everyone for joining today. We'll wrap up this PHAB Accountability Metrics Subcommittee meeting. I'm going to